Hello, my name is Ronnie Pernbaya, and this is my Kinesiology 353 critical assignment. And it's on basketball injuries. And then let's get started. So the first injury we're going to talk about is the inversion ankle sprain. It's one of the most common injuries in basketball. I know I've suffered multiple ankle sprains over time until I realized that I got to do something about it and started to take some preventative action. Anyways, it's graded as 1, 2, and 3. Grade 1 is just minor tears. Um, grade 2 is partial tears. Grade 3 is, I believe, 75% torn to a full tear. It can also be coupled with a syndesmotic sprain, which is the high ankle sprain. However, you won't see the high ankle sprain without having the lower sprain. So they come together. So the mechanism of injury for inversion ankle sprain is, of course, forceful inversion of the ankle, or the foot will tend to roll inward or under. Looks very painful there from the picture on the top. A lot of times, it can come either a number of ways. It can come from contact, as in if you're jumping for a rebound and you land, you come down on someone's foot, or you come down and you don't land evenly, and your foot will roll inward. It also can be from non-contact. A lot of times it is from sudden stopping or sudden changing of direction. As you see on the bottom picture there, it's not really touching his leg or anything, but he is trying to do a move, and that motion, that sudden forward stop and push back, looks like it's causing a sprain to that ankle there. So if you look at the anatomy of the ankle, you can see that the lateral ankle is made up of 3 ligaments. The ATFL, or anterior talofibular ligament, connects the talus to the fibula. The CFL, or the calcaneofibular ligament, connects the lateral fibula to the calcaneus. And the PTFL, which is the posterior talofibular ligament, connects the talus to the fibula back, posteriorly. Most of the injuries will occur to the ATFL and the CFL, just based on the mechanism of injury, which is inversion and plantar flexion. So to find out if you have or if your athlete has the ankle sprain, you want to do an anterior drawer test, and that is to test for the ATFL. So by doing that, you are with one hand stabilizing the tibia and giving a posterior pressure or posterior force, and with the other hand you are holding at the calcaneus and producing anterior force pulling up. And you're looking for laxity in the joint, like a mushy end feel. You're looking for, like I said, laxity compared to the other side. So it's always good to test both sides and see. They could be just a pretty lax person, and you may think that they have an ankle sprain on that side. But if you look at the other side, it's pretty much the same. You know, maybe they're just hypermobile. I have also included a link there to see if you want to look at that test. There's a small video. Another thing that you want to do is also determine if they're able to walk on the foot. These are some functional tests. See if they can put any weight down into the foot. Have them walk on their toes, have them walk on their heels, and then just assess and see if they are favoring a certain side, if they're avoiding putting their whole foot down, or they can't put their foot in a certain position, and then just take note of that when you're doing your assessment. So the treatment for ankle sprains, initially you want to RICE, perform the RICE method, which is rest, ice, compression, elevation. And this is for most injuries to soft tissue and ligaments. You want to RICE. A lot of people will want to put heat right away. In my experience, a lot of people want to throw heat on there, but in my experience, you can never go wrong with icing. So always recommend ice because it helps to decrease inflammation, helps speed up the healing process. So you want to do that. If you have a higher grade injury, you may have a splinting or casting by the doctor. They may keep you in that for a few weeks to a month or a little bit more. That's just to keep the ankle in a neutral position. Like I said, the ankle is in an inversion and plantar flexion, so your ankle would want to stay that way, and you don't want that. So you want to keep it neutral. And then after that, you'll go to do some rehabilitation exercises. You'll be in 3 phases. The protection phase, it's like it says to protect it, so you want to get rid of the edema, you want to get rid of the swelling, you want to just basically keep that safe and keep the ankle in a safe position. And after that, you want to regain your range of motion and the flexibility. You'll probably have a lot of tightness in the calves because of the tendency to stay in plantar flexion. And you want to regain the strength in your ankles because, again, if you stay in plantar flexion, you may have some muscle imbalances with your anterior tibialis and your post-tib, and you want to regain the strength there as well as the strength in your hip and your knee because you're not putting as much weight into that ankle over time. And then thirdly, you want to return to sports, and you'll work on balance and reactive exercises in that phase. Here's the exercise prescription for the ankle sprain, including preventative and rehabilitative exercises. I'm providing a link at the bottom there for you to see a few of those exercises demonstrated. Moving on to the anterior cruciate ligament, or ACL. There's a serious ligament injury of the knee. Your knee has 4 major ligaments that help stabilize it. The anterior cruciate ligament, posterior, medial, and lateral ligaments all help to keep the knee stable. But the anterior cruciate ligament, as we'll learn later, as we'll look at in a later slide, it prevents anterior translation of the tibia during open chain, things such as kicking, and posterior translation of the femur during weight bearing. So you can have a partial tear of the ligament, or you can have a full-on tear of the ligament where it totally ruptures. But mostly it's from sudden stopping, jumping, or changing direction. As you see in Derrick Rose there, we know if you follow basketball, he did a lot of crossovers. He was a high flyer, and he did a lot of changing of direction in his time. And eventually he had an ACL injury, and a lot of people would say that he was not the same after his injury. Another note here is that it's more prevalent in female athletes. This has been said to be due to muscle imbalances between the quad and the hamstring, also between structural deviations of their hip and their Q angle, which we'll kind of look at a little bit later in the slides. So the mechanism of injury is mainly from non-contact, so it's from deceleration, like we talked about earlier, sudden stopping, sudden changes of direction, and what happens is when the foot becomes planted and the knee extends, if excessive knee valgus or internal rotation occurs, then that puts a lot of stress on the ACL, and then you get those tears, those pops. A lot of times you'll be in that position already. You'll be foot planted and the knee extended, and then the knee valgus, and it's getting strained, and then you receive a hit from the outside. That's when it just makes it worse, and then the tear actually happens. Another thing is landing on a single leg with the foot externally rotated has been found to increase the chances of injury as well. I think it's because it tends to put more knee valgus as a compensation for the external rotation. So the anterocruciate ligament, as we said earlier, it limits posterior femoral motion during weight bearing, stabilizes the tibia against external internal rotation. And also the hamstrings have a aid in the hamstrings aid the ACL in those jobs. And so I think that's why, as in my reading that I found, in females especially, since the quads were overpowering the hamstrings in most females tested, that was the reason why they tend to have more injuries, um, in comparison to men, was their decreased hamstring strength. So some special tests for the anterior cruciate ligament are the anterior drawer and the Lachman's. I provided some links so that you can see. For the anterior drawer, it's performed in 90 degrees of flexion, while the Lachman's is the preferred method and is performed in 30 degrees of flexion, which is the open pack position for the knee. Basically, one hand provides a posterior pressure to the femur, while the other hand provides an anterior pull underneath the tibia, and you're looking for laxity there, some pain or discomfort there. Why the Lachman's is preferred is because since you are in a less flexed position, there is less chance of you contracting the hamstrings during the test, which may give you a false negative sign. There's conservative treatment and there is surgery. If you would qualify for conservative treatment if you were not planning on returning to any sports, if your job is not highly demanding, or if you didn't have any other concomitant injuries like a meniscus tear. However, if you did have a meniscus tear or you were trying to return to high demand sports like football or basketball, volleyball, things of that nature, soccer, then you would have reconstructive surgery. And in that case, you'd have two, more than two, but the two main choices are a hamstring graft and a patellar tendon graft. The patellar tendon graft is good for return to sports. The hamstring is less painful, however. Then there is the exercise prescription for the ACL injury. Again, I'll be providing a link on the bottom. And finally, patellar tendonitis, also known as jumper's knee. It occurs due to repetitive motion, repetitive jumping, repetitive running, and it basically is, over time, all that running, jumping tends to inflame the patellar tendon. We'll look at that in anatomy. So again, repetitive jumping, running happens in basketball all the time. And as we look at the picture here, so the patellar tendon is the tendon that you can see on the bottom there that's kind of pink, and it is connected to the tibial tubercle on the bottom. So when the quadriceps contract during jumping or running, it pulls the patella superiorly, and it puts strain on that patellar tendon on the bottom. And all this repetitive motion, that repetitive pulling, will cause inflammation at the patellar tendon, and also will cause some minor tears over time. And so, if you keep playing, you keep doing those things, there's no time for that to heal. There's no real special tests for patellar tendonitis. There's a few, just basically palpation, tenderness at the tendon with activity, or even without activity is a sign. Q angle over 20 degrees, A angle over 35 degrees, correlates with PFPS. Some of the treatment is, of course, RICE. Patellar strapping helps to apply pressure to the area. Transverse friction massage has been shown to help with patellar tendonitis, and of course physical therapy with a focus on eccentric quadriceps loading, because that helps to gradually load the patellar tendon. And here's the exercises for the patellar tendinopathy or patellar tendonitis, and again I'll be providing a link at the bottom. Sorry for rushing towards the end there. I just know I'm reaching the 15-minute mark that Screencast allows me. Here are my references. I hope you enjoyed this presentation, and thank you very much.